You see, when you get a patient of right upper abdominal pain and fever, you have to see few things. First of all, what is the age of the patient? This is an elderly patient. Okay? Sex of the patient, he is a male. Then duration of fever. For how many months he was, or how many days he was having fever?
Alternately, 3 episodes.
Three episodes on the
3 days.
or last 3 days.
Last 3 days.
It was high grade or moderate or lower grade?
So more than
100, 100 degree Fahrenheit. And there was associated with chills and rigor or not?
no episode.
No episode of chills.
Different.
Okay. Any history of vomiting? Any history of loose motions? Okay. Is he an alcoholic? He is an alcoholic. And is there any history of jaundice or dark colored urine?
During the course of admission, patient in my
So if you have a patient, elderly patient of this age, and he is having high grade fever and also abdominal pain, especially in the right hypochondrium, then you have to think of few things. First of all, you have to think whether this is related to the episode is related to liver disease or biliary disease. Now, in a biliary disease, it's usually because of gallstones. And then you will have radiating pain to the right shoulder. Is there any history of radiation to the right shoulder? No radiation. Then, if there is fever and pain in the upper abdomen, it is generally considered to be involving the right side, which is the liver. And in the liver, the most common condition is hepatitis, followed by liver abscess. So hepatitis is most of the time may be associated with jaundice, and liver abscess may or may not be associated with jaundice. So there is no history of jaundice in this case. Now then you do the vitals, which you said was temperature was normal at that point of time and tachycardia was not there. So that means the patient has taken some antibiotic or some medication. Now in the examination, you have to see the abdomen. Now since this is post management, so he has got some dressings over the areas which have been drained, and on inspection the abdomen still appears to be distended, and he is having normal respiration, and on palpation there is no tenderness on the left side, no tenderness in the right iliac fossa. There is some structure palpable under my examining finger, and that is the liver, and there is some tenderness also, as you can see the wincing from his face. And this is the costal margin, and my finger is about 4 centimeters from the costal margin. So he has got an enlarged liver, which is tender on palpation. So that indicates that this hepatomegaly and associated with fever is generally likely to be either hepatitis or it is likely to be a liver abscess. Now this patient was investigated, and on investigation, what were the findings of investigation?
After the ultrasound of the
No, counts कितना था?
WBC count when he experienced 16,000 WBC count.
When he came, WBC count was 16,000.
16,000.
And ultrasound report was suggestive of
Ultrasound suggestive of the multiple liver abscess, which is highest measuring liver abscess, is 6.8 centimeter with a volume of 162 cc.
and there was rupture of one of the abscesses.
One of the largest cavity of the liver is ruptured.
So that resulted in fluid in the peritoneal cavity. So because of that, this patient was taken up for management on an urgent basis. So first of all, he was resuscitated. He was given antibiotics.
Initially, we had conservative treatment with that.
He was given IV fluids, antibiotics, and then a drainage tube was inserted in the abdomen to drain the pus which was there in the peritoneal cavity. Then he was shifted to the ultrasound room where percutaneous drainage was done. A pigtail catheter was inserted in the largest cavity for drainage of the abscess, and multiple abscesses were observed in the liver. And this largest abscess cavity was 6.5 centimeters, which was drained.
Which was drained 162 cc. Also we sent a pus culture.
Pus culture was said. What was its positive?
Still, sir, no, sir. It's not positive for FEB or sir, no organism is.
No organism has been isolated.
But it's not a pyogenic.
Huh?
It's not kind of pyogenic.
That we don't know because he may have received antibiotics. So, the drainage was done, pit-tail drainage was done, and after 2 days, bile was observed in the drainage tube. That is one of the complications which can occur when you are putting this tube inside the liver. So after that, we pulled out the tube, and following that, the patient is getting better. And now both the drains have been removed. The pit-tail drain, which was there in the cavity, which was draining bile initially, and pus also in the earlier phases. So the pus has been drained. It was yellowish in color. And later on, after some time, bile started coming. So there may be communication between the liver radicals and the tube which was in the cavity. So after that, the patient is getting better, and the second drain which was in the pelvic, in abdominal cavity is also being removed. Now the patient is improving. Now the only thing which I want to point out, there are two types of abscesses in the liver. One is pyogenic and other is amoebic. So amoebic is more common, and again these patients are usually alcoholics, and they are in the middle age, between 40 to 60 years. This is an elderly patient. So the etiology of the two conditions is different. One is caused by intermedia histolytica. This is fecal-oral transmission. The food goes inside and then it settles in the GI tract. From the portal vein, the parasite goes into the liver, and in the liver it sets up an abscess cavity. So that is intermedia histolytica leading to amoebic liver abscess. Whereas in case of pyogenic liver abscess, it is because of the bacteria which are in the liver or in the biliary channels, usually following gallstones in the CBD or in the gallbladder. And these stones and causes obstruction to the bile, leading to stagnation and multiplication of the bacteria. And this bacteria goes inside the biliary channels and lodges in the liver. So the main difference in the two is, one is, and this is one way of infection. Second is by infection in the organs of the abdomen, like appendix. So there can be appendicitis, there can be diverticulitis. Also trauma is one of the factors, penetrating injuries of the abdomen. So there are three ways in which a pyogenic abscess can occur in this patient. One is by biliary trees infection. Second is by GI tract like appendicitis, diverticulitis. Third is by penetration. And the fourth source is by generalized hematogenic infection. There may be abscess somewhere else in the body, and by hematogenic spread it may lodge in the liver. So the main difference between the liver abscess in the pyogenic liver abscess and the amoebic liver abscess is that a pyogenic liver abscess has multiple cavities of different sizes, usually small size, say 1 to 2 centimeters. Whereas a amoebic liver abscess has a large cavity and usually in the right lobe. So the treatment of the two is depending upon the condition. If the patient is having pyogenic, it's a more serious condition, and the patient is having a high grade fever and patient is sick also. So you have to do proper resuscitation. You have to start broad spectrum antibiotics and see the culture once you aspirate it. If the culture is positive, or you get first you start with empirical treatment, and then as soon as the culture is available, you switch over to the antibiotic which is the patient is sensitive to. So initially at least 1 week or 15 days is intravenous treatment, and then if the patient resolves, patient's condition gets better, you can put up on oral therapy. And at least 6 weeks of antibiotic therapy is required to completely eliminate the cavity. And serial evaluation of the ultrasound guidance to see the cavity is collapsing. Whereas in amoebic liver abscess, this is a single cavity most of the time. Patient is not so toxic. Patient can be managed just by antibiotics, that is metronidazole. But many times, if the cavity size is more than 5 centimeters, then you have to do an aspiration, and multiple repeated aspirations will be sufficient for treatment. So there is not a, all the time it is not needed to put a pigtail catheter. But in a pyogenic liver abscess, since it is a serious condition and multiple bacteria are there, it is always better if the cavity size is more than 3 or more than 5 centimeters, you have to put a pigtail and accordingly monitor the condition of the patient. So in this case, we have put the patient on pigtail, and since the cavity was ruptured, also in the peritoneal cavity, there was bile leak which has been settled. Overall, the patient's condition, he is afebrile, he is asymptomatic, and he is able to take normal food. So this is the right time, we can discharge him, but he will get antibiotic therapy for another 4 weeks. Thank you very much.